Hey guys, let's talk about chronic obstructive pulmonary disease because this lecture we did not cover in class, so I wanted to make sure I will record it for you. So, what is COPD? We abbreviate it as COPD. It's just easier to say it. But pretty much, COPD is a chronic lung disease of the respiratory system. It's preventable. We can do many things to prevent it, like not smoke. For example, smoking is one of the leading cause of COPD, but it's also progressive and irreversible. So patients with COPD will get worse and worse as the time goes, and they cannot reverse it and be okay or normal lung function. It's usually characterized by this inability of clients to expel CO2. So the airway kind of gets obstructed and they hold on to the gases like CO2 and they cannot do this gas exchange accordingly. It's more common in males, and honestly, a lot of people suffer from the disease, and are hospitalized constantly throughout the year. You will see them in the hospital where they come in with COPD exacerbation because once you have the disease, you can live outside of, your, kind of like have your normal daily life. But whenever something exacerbates it, for example, a infection or maybe allergies, or maybe you got the influenza or COVID, then that's when you will require hospitalization. It's the third leading cause of death in the United States, and it's more common in white people and not so much in Hispanics culture. Some other risk factors include a autoimmune disease, especially age and gender, occupational jobs, for example, jobs that expose you to very irritant particles like sand or paint particles that you're breathing in. A little bit of the patho is that, you have these particles that literally aggravate and irritate the mucosa and the respiratory system. Then this inflammation happens. The immune system says, well, this is not supposed to be here. They trigger all these cytokines and, your T cells and whatnot. And so inflammation happens, that creates airway obstruction. It starts destructing the alveoli. So then you don't have the gas exchange. And then the vascular system within the respiratory system also has some changes. That leads to a lot of mucus production. The alveoli literally change its shape. They become like really almost like hyperinflated. So their function is not correctly. They lose elasticity. Their chest becomes like really wide. And then primarily they have this impaired gas exchange where they are retaining carbon dioxide. Here's a little picture so you can see how kind of like the changes that it takes. So, the airways become very constricted. You got that mucus. And if you notice here on the alveoli, they're losing its shape. They're not pretty and round anymore. They're almost like oval and just sort of have a dystrophy to them. Here's another one. All right, so what do these clients look like? What do they experience? Well, they usually some of the symptoms that are very hallmark, they have this chronic cough, and it's intermittent, but it's like wet and sometimes like hacking. Not always do they have sputum, but they have this sort of sound, deep, wet cough. They'll show difficulty breathing and easily fatigue. especially with activities. So they feel tired because of their lack of oxygen. They have this chest that is sort of like wide on the top, and they kind of sit forward because they're trying to exhale the CO2 and kind of catch their breath. That's what the tripod position means. Their nails become clubbed and kind of wide because of the lack of oxygen. They have wheezing. They have decreased breath sounds, and their ankles start swelling because it affects their heart as well. There's a big correlation between the respiratory system and the cardiac system. And so they'll develop eventually like heart failure and whatnot. So you will have some edema on there as well. Their color looks a little different, like their skin color. They kind of look like dusky, kind of grayish at times. But that's again from the lack of oxygen. Here's a picture of the clubbed fingers, the barrel chest, and the tripod. Feel free to pause any of these so you can take a look at it a little carefully. So as I was saying, they do complicate or they sort of have other complications that leads them into the hospital, and we call that COPD exacerbation. And that's kind of what leads them to be hospitalized for days, for us to control the inflammation, for us to control their breathing and their saturation, give them medications. And many things can lead to this, even running out of their maintenance bronchodilators and steroids. Can throw them into an exacerbation, as well as heart failure or respiratory failure in worst case scenarios. We diagnose COPD by spirometry as well. It's actually necessary to diagnose COPD because let me review a little bit of the spirometry. It basically tells the physician how much air is being pushed out and being exhaled during this like full breath, like when you're forcing the breath out, how much air is it coming out? And so and they do it without medication, like a bronchodilator, and after the bronchodilator. And so that's actually similar to asthma but in COPD, it's actually necessary to be diagnosed. They also look at chest x-rays and ABGs for respiratory acidosis, and they'll eventually, as you're being diagnosed, or if this is the first time you get admitted with COPD, they'll do a 6-minute walk test. What that is that they'll test you without oxygen, like just ambulating, and then they'll monitor your oxygenation, like like sort of like your O2 sat. And then as it starts dropping, they'll put oxygen if needed. And then if it if you need some more, then they'll add a little bit more oxygen just to sort of maintain the client at about 92 or 93%. That means you can ambulate, but your body's requiring more oxygen. The demand is higher and you cannot supply it. So therefore we need to supplement oxygen. And so it's sort of one of these tests that we do in order to go home or to determine if the client needs oxygen at home. So let's look in the overall picture at what the overview of the management of COPD looks like. Well, as I said earlier, it's mostly outpatient unless we have a complication like an infection. Um, Very important, these COPDs sort of consider a comorbidity, so these clients usually have other diseases like, asthma, diabetes, cardiac issues. So they're encouraged to take their influenza and the pneumococcal vaccine, the pneumonia vaccine, stop smoking if they're smoking, because that's the leading, the first leading cause of COPD. You want to do anything to expand the lungs, whether that is sitting them in a tripod position, elevating the head of the bed, um, ambulating, just anything that doesn't keep them just with their lungs not moving. And also where they could take a full breath and also expel the CO2 that is being caught inside. So for here, this is another one that we need to pay attention. How do we teach our clients to expel the CO2? Well, we teach them pursed lip breathing, just kind of from their lips, like a duck, or like they're gonna kiss you in your cheek, and then just expel it. Oxygen really doesn't fix the problem in CO2 COPD clients because the problem is not the oxygen. The problem is them retaining CO2. So that their airway needs to be open, first of all. Then you have all this mucus, which is not allowing the CO2 to come out. So they first need to open the airway in order for the breathing to be effective. Also, they will experience sort of like this breathing pattern that is not effective. They might be a little tachypnic and short of breath and huffing and puffing. You kind of want to control that first as well. Most of these clients are not at 100% oxygen level. They sort of live in a 95, maybe a 92. I've seen clients, COPD clients that are normally at an 89%, and that's where they live. So you don't want to like say, oh yeah, they're at 89 and let me crank up this oxygen to attempt to get them to 100 because they don't live there, they normally don't. And so you're actually not doing anything good for them. The medication therapy is similar to those in asthma. You're going to do bronchodilators like albuterol to dilate, open up the airways and the pipes. You're going to do steroids to help with inflammation. Remember, there's a lot of inflammation and mucus creation. So we need to sort of calm down the inflammation in the airway with steroids, inhale steroids. Also, anticholinergics, they sort of work hand to hand with the bronchodilators, but anticholinergics, such as ipratropium, help with the smooth muscle around the airways not to constrict, and therefore it relaxes and dilates. So it's a very good drug for them. You can also do CPT, chest physiotherapy. It's vibration of the chest to break up the mucus and also, kind of helps with airway clearance. Just when they have all that phlegm and mucus around the airway, it's difficult for them to breathe and really do that good gas exchange. So if we break it up and let them cough and deep breathe, and they might be a little bit better. It's really debilitating. It really takes a lot of their energy. Imagine, you can't breathe. You're tired even just walking from the kitchen to maybe your room, then trying to get dressed. So we kind of cluster their care. We also collaborate with physical therapy and PT. I'm sorry, not PT, OT, occupational therapy. Occupational therapy differs from physical therapy as occupational therapy deals with your ADLs, your activities of daily living, like shower, dressing, cooking, stuff like that. Physical therapy helps you with your strength, with um, exercises to get you to learn how to breathe and move at the same time. And they need to learn how to do that. They need to learn how to walk and breathe at the same time and not hold their breath. Um, because it is very debilitating as well. You're gonna need a good nutrition full of calories, protein, minerals, maybe space out their meals, small and frequent meals. Um, and sort of kind of pleasure meals, like whatever they like to eat, because they're more likely to consume it, and also um, kind of rest um, before they're gonna go eat, and then also kind of exercising a little bit or working out themselves a little bit about the time that they're gonna eat, so that way they're hungry, because they kind of lose a little bit of the appetite as well. You'll supplement oxygen as needed, and then huff coughing. This is an effective technique to cough off all the phlegm, and it is sort of a forceful cough, like you know. Your book talks about it, and it explains sort of what you teach your patients to do. I really encourage you to look at that in your book, under the respiratory assessment chapter. But yes, it's one of those techniques that we also implement with COPD clients. Here's the pharmacological therapy: anticholinergics, anti-inflammatory, bronchodilators. These are reviewed from the asthma lecture. Keep in mind the bronchodilators, the SABAs, they can get you blood pressure, tachycardia, dry mouth, tremors. They are effective, in minutes, and they last about 2 to 5 hours. Anticholinergics, they're sort of secondary, and they usually use them together with bronchodilators. Um, they could give you sort of dry mouth, tachycardia, and urine retention as well, and blurry vision. So those are some of the things that you want to teach your clients about. And then on the anti-inflammatory, your inhaled corticosteroids, you want to make sure that you rinse your mouth after the steroids, so that way you don't develop any thrush. Another part of the COPD management is their oxygen therapy. And so you're going to find this in your book. Oxygen, we try to titrate the goal to about 80 to 90%, sometimes 92. You kind of have to assess what the individual was originally on, what was their normal percentage, and now what the severity of the condition is. Okay. But remember, oxygen does not fix everything, does not fix the problem. It's a CO2 retention issue. When you think about oxygen, you need to know what device provides how many liters and what is it normally used to treat. So, for example, if someone is not breathing accordingly, you have them on 2 liters and of a nasal cannula, and now you're going to put a single face mask. Then you cannot put the single face mask at 4 liters, because the single face mask needs to be up to 6 liters to 12 liters of oxygen. Same with the non-rebreather, you got to put the non-rebreather at a 10 to 15 liters. So you kind of need to know those levels, um, and what device is used for, the level of oxygen or the amount of liters. In addition, other things to think about is no smoking or anything flammable up around the oxygen. You always want to consider skin integrity. For example, around their ears, around their nares. If it's a face mask, then, kind of like the bridge of the nose or their chin. You can provide humidity with oxygen. It kind of helps people not have this mucosa so dry. you always have to look at the flow meter here on the wall, and here's the picture of it. We call it the Christmas tree, the green Christmas tree, because of their plug at the end. And so every time you walk into a room, you really want to look at how many liters of oxygen is my patient, and by looking at the flow meter. You want to wash your nasal cannula with soap and water or replace every 2 to 4 weeks. You want to provide them with a lot of oral care because their mucosa gets dry, and they're having constant oxygen being delivered to their mouth. If, for example, they are using this nasal cannula at home and they are sick, it's advised to change their cannula if they've been sick. So kind of there's a teaching that goes with the oxygen therapy that we as nurses need to know, and you should know as well for the rest of your career. All right, so let's talk a little bit about more of kind of like your ADLs and your nutrition. I kind of mentioned this a little bit, but we want to conserve some energy because they get very fatigued, kind of cluster their care, kind of spread it out throughout the day, and maybe say, well, I'm going to rest an hour before I go take a shower, or I'm going to go bathe just because I know I'm going to be tired. Um, Same with, I wouldn't recommend, let's say, having a meal and then going to take a shower. You just got tired of eating because you're, short of breath. Kind of rest before you go take a shower. With the nutrition, it's recommended for you to rest 30 minutes before eating and use a bronchodilator. Sort of get moving a little bit before, because that opens up your appetite. And as I mentioned earlier, like they sort of, because they're tired, they sort of tend to not eat. So you kind of want to make sure that they get a good appetite or provide meals that they like. Um, Avoid any activities 1 hour before or after meals. Apply oxygen if you need it. For example, if you're going to apply oxygen to someone that is going to be eating, you don't want to do a mask, right? Because then how are they going to eat? So you might need to go to a high flow nasal cannula, or a nasal cannula while they're eating. High calories, high protein snacks in between meals, especially those high protein snacks like supplemental drinks, Ensure or Boost or whatnot that the client might need. And then careful, this is a little side note here, careful with sedatives and narcotics with people with CO2, because let's think about this. The sedative and the narcotics depresses their respirations. So they're already not breathing at the appropriate rate, and in consequence, not releasing the CO2. So we're basically affecting more these clients that are already retaining CO2. So you kind of want to be very careful when you basically combined sedative, narcotics, tranquilizers on these clients. Okay, well, that's kind of like an overview. I hope it was helpful, and I will see you in the next lecture. My references, as always, are from the book, and all my images from Google or the book. Bye-bye.